Hello and welcome. This is Jamie Passmore. I'll be covering your COPD introduction, primarily covering your pathophysiology and the etiology of such. So if you want to follow along, this is going to be in chapter 28 of your MedSurg textbook. If you have the new version, which is the 12th edition, that's going to be a different chapter, which is chapter 31. So just to talk about the COPD description and what it really is, an easy definition is it's airflow limitation. That's not fully reversible. It is a progressive, typically. Sometimes it can get a little bit better based on response to medication, treatment, therapy, that type of thing. It's an inflammatory response, and it's because of exposures to certain things, typically, most common, cigarette smoking. Now, of course, there are other types of causes that can cause COPD, as well as COPD exacerbations or worsening of the disease. Things like air pollution or occupational exposure, infection, asthma, and then, of course, we've got some aging processes that can also lead to exacerbation or worsening. So let's just kind of dive in and talk about some definitions, the causes, really dive into cigarette smoking and some of the main effects of nicotine and the actual smoking. So when you think of COPD, if you've ever learned about it or researched it, or if you've ever been taught COPD, most people teach that COPD is a combination problem. So it has at least 2, maybe 3 different separate disease processes within COPD. And most commonly taught, chronic bronchitis, emphysema, and asthma are the 3 components of COPD. However, not all patients are going to have all 3. But typically what they will have is the chronic bronchitis and emphysema. Asthma may be included, but typically it's a existing condition that clients typically have. What COPD typically will start with is the chronic bronchitis and emphysema, 2 separate types of problems. And we'll talk about what those really are in a little bit more depth as far as the patho and causes and things like that. So in order to really get diagnosed with COPD, this is a nice to know. Most commonly, your providers are going to say, okay, you've got bronchitis, and we've diagnosed you with bronchitis, and now you've got a trend showing that you've had bronchitis at least 3 times in 2 consecutive years, or at least 3 months in 2 consecutive years. Let's do some more diagnostic testing and see what's really going on. Maybe you've got some COPD, and so they'll do some diagnostics, which typically are going to include things like your airflow assessments. They're going to look at maybe their spirometry, walking tests. They may even do some genetic testing. Kind of depends on what the assessment, the health history is going to look at. But, we start seeing a trend in things. And one of the first things we really want to assess on our patient, even as a nurse, is to get some history, get some risk factor assessments in. When a patient comes in with a respiratory problem, ask those questions and don't be afraid to really ask about cigarette smoking. And typically, most patients are going to be pretty truthful with you if they do smoke, but you want to go a little further and ask what kinds of smoking they utilize, because we know there's all different variations of smoking now. And some people may think that cigar smoking and cigarette smoking are the same, and they are not. Some people may think vaping and cigarette smoking are the same, and they are not. So, really make sure that you ask. And then you also want to know how much they smoke per packs per week, and then how long they've smoked in years, and you multiply that and you get packs per year. And that's where we kind of plug in, if you've ever seen diagnoses that are in medical charts, we want to know what category they fit in. So we want to know packs per year as part of that risk factor, and so making sure that you're collecting that data. Another third thing that most nurses don't really think to ask with cigarette smoking assessment is, have you ever tried to quit, and what methods you have used? Excuse me. So if a patient has attempted to quit, that shows initiative to quit again. And maybe they're not using the correct methods. Maybe they don't have the correct coping, mechanisms. And maybe they need some more resources or some assistance in smoking. We know there's lots of smoking cessation options out there. We also want to ask about chemicals and exposures to things. So occupational exposure is a risk factor in addition to cigarette smoking and separate from cigarette smoking. So that's why we want to ask both of those. So when I'm talking about occupational chemicals and dusts is the different types of fumes, smoke. Think about farmers in the South. What are they exposed to? And especially in the fall months, fields burning, the farmers and even the nearby neighbors are inhaling that smoke and that pollutant. So asking about any chemicals or dust exposures. We also want to ask about occupations, because another option is clients who have worked in factories, who have been ex-military in the past. They may have been exposed to something and they're not smoking, but they've got all of those classic symptoms of a COPD. Of course, air pollution can also be a problem there as well. Severe recurring respiratory infections. And think about your upper respiratory infections, like anything that can cause an inflammation. Then we also have our lower respiratory infections like pneumonia, tuberculosis. Those can also lead to COPD. So we want to get a good thorough respiratory history and then exposure history. If we're not really seeing a pattern in our patients' exposures or infections, then we may also want to look at what's called the A1 antitrypsin deficiency, or AATD. This is an autosomal recessive disorder, which means it's familial, so a patient's family member can also have this. And typically it's going to be those first degree relatives, parents, siblings, children. And what you need to understand about the AAT, the alpha-1 antitrypsin, it's a protein that's typically made by the liver and can be also found in the lungs. It's normal. We have the protein. When patients have a deficiency of the protein, then the function of the protein isn't working. And the main overall function of the protein is to prevent inflammation in relation to infections or smoke inhalation. So that makes sense. If a patient is lacking this protein that protects us, we're going to be at even higher risk for developing that severe inflammatory process that can lead to airflow limitations. So even if they're not a smoker, maybe they've been exposed in the past, they may not even remember being exposed. It can be something as simple as going to a party and being around a lot of cigarette smoke, or again, if they live in the South or anywhere where there's a lot of dust and chemicals and they're inhaling that, if they don't have this protein, they can't protect themselves. So they may end up with COPD. When that's the case, it's very, very easily missed and it's underdiagnosed severely because we're linking it to so many other etiologies. But we are seeing in research that the AAT deficiency is definitely an option out there. So making sure that you're really getting a good thorough assessment on that. So let's talk about cigarette smoking, and I'm probably going to do a little overkill. I've got about 3 or 4 slides just on cigarette smoking because I really want to emphasize that the most. The reason for that is because of the statistics. People with COPD that are diagnosed with COPD develop because they smoke, and 15%. That's a large percentage of patients that have been smokers that develop COPD. So when we look at COPD, always ask about cigarette smoking and making sure that you are getting a thorough smoke history. And when we're linking that up and kind of plugging that data in, something that should kind of pop your ears up is that a patient who is over 40 with a smoking history of 10 or more pack years, which means that they've smoked for more than 10 years. So that should really cue you in and do some more thorough assessments on there. So let's talk about the effects of cigarette smoking and nicotine and all of the body effects of that. So nicotine itself has an effect, not just the smoke and the tar and all the things, but nicotine can cause a stimulation of our SNS, or sympathetic nervous system. Remember, this is our fight or flight. So this can increase the heart rate, okay, which puts more workload on the patient. It also causes peripheral, so outside, not central, but peripheral vasoconstriction, which is then going to increase the afterload or the resistance that the heart has to work against, which is in essence going to cause even more of a workload. And because of that peripheral vasoconstriction, it can also increase their blood pressure. So you kind of see this tandem effect of cigarette smoking and nicotine and all these other comorbidities like hypertension, heart failure, COPD, right? Even diabetes can also be all linked to that. So when we're teaching our patients about cigarette smoking, making sure that we understand what the effects are so that we can provide that for our patients as well. This is also found in your textbook. There's a little table. If you're in your Med-Surg, the 11th edition, then this is Chapter 28, Table 2816, and it's just the effects of what cigarette smoking does on the respiratory tract. And essentially what it is just a domino effect of the damage that they're causing to their lungs. Now, does one cigarette cause COPD? No. But does one cigarette possibly cause inflammatory process? Absolutely. So anytime we put something noxious in our body is going to try to fight that off with its natural inflammatory process. And for you to understand that and really make sure that sticks into your brain is also going to help you with the process of the effects of COPD and its exacerbations. So when patients smoke or when they have some kind of noxious anything that they're inhaling, it's going to cause hyperplasia of the goblet cells. Fancy way of saying we're getting lots and lots of mucus production, and that's part of that pro-inflammatory process, and we'll talk about that again a little bit later on. What we want is for that inflammatory process to come and go, right? But in COPD, with a history of cigarette smoking, we're constantly, especially if they're really smoking, we're constantly inflaming our respiratory tract. That's going to eventually cause dilation and destruction of our alveoli and inflammation and damage to the parenchyma of the lungs. So we want to try to quit that. There's a statistics out there, there's a statement out there about if you quit smoking, it can actually cut so much years off of your respiratory problems, and those are all theories. Those are all great, and you can use that if you need to provide your patient information, but it needs to be factual. Okay, so making sure that you're really giving them the full picture and the effects. Another effect that we typically don't think about when we think about nicotine. Now, nicotine, yes, vasoconstriction. It definitely is going to cause activation of the sympathetic nervous system, even though we think breathing in and breathing out, it kind of calms me down. Yes, but it also speeds you up, and that's why you get dopamine and you feel better after smoking a cigarette. Another effect of nicotine that we don't think about is it can actually decrease and reduce the amount of functional hemoglobin. And functional hemoglobin is our key word. And that means that we might have a normal amount of red blood cells, but the amount of functional or working hemoglobin is not there. So we might actually have a lower MCH, but a normal H&H in our patient. And so what we're going to notice is our patient's oxygen carrying and iron carrying capacity is diminished. And so then we're going to have some problems later on, and we'll talk about that in a second, of carrying oxygenated blood to our vital tissues. Nicotine can also increase platelet aggregation or clumping. So platelets that clump cause clots. And when clots develop, when our patients' blood vessels start to recognize those clots, inflammatory processes go to that, builds the clots up even more, puts them at risk now for VTE, or venous thromboembolisms. And of course, any kind of embolism is what we're concerned about. So we don't want platelet aggregation. And this is why it really compounds problems in patients with a history of coronary artery disease as well. Carbon monoxide, so the actual breathing in of the carbon monoxide, we know is going to decrease the actual ability for oxygen carrying capacity, right? So we understand that part. But another piece that we need to understand is that's also still going to increase the heart rate, because the heart's going to compensate to get as much oxygen blood to the tissues because it's lacking that amount. That puts more workload on the heart and places them even more higher risk for cardiac difficulties and even more respiratory difficulties secondary to that. When we don't have enough oxygen carrying capacity, we don't have perfusion to our vital organs. And so that's why we see patients with possibly impaired psychomotor performance and judgment. So not necessarily confused, but their brain is not getting the perfusion, so their thought process is not the same as it used to be. So they may have a little more riskier behaviors. They may not realize what they're specifically harming themselves with. Oh, this one cigarette's not going to hurt anything, I'll quit tomorrow. You know, that's poor judgment, and that's part of the actual parenchyma of the brain as well. Another little note about cigarette smoking, and I promise this is the last one, passive smoking. So just that secondhand smoking, or ETS, is still a risk for COPD development or even complications later on. And we really need to think about pediatric patients' exposure to passive smoking or secondhand smoke, because that's going to also still do the same thing. It's going to decrease their pulmonary function, increase those respiratory symptoms, just like any other smoker, and then of course place them at higher risk for lung problems, sinus cancer, or anything else that's going to be respiratory related. So just because a patient is not smoking, we also want to ask, have you been around smoking? Have you been exposed to secondhand smoke? And again, really focusing on the pediatric patient. To touch on occupational environmental resources or exposures, again, anybody with COPD can develop with intense prolonged exposure too. So really making sure you're asking about what their occupation is, especially if they've not been in good ventilated areas, if they have work with fuels, or if they have been in the military. I don't know if I said that or not. Any kind of exposure to dust, vapors, irritants. So just kind of get an idea of where they work. And that kind of leads you into some questions. Well, what do you do at work? What have you been exposed to? Infection, and I've got two big ones right there, but of course, anybody with respiratory tract infections, especially when they're chronic and severe, can still impair the normal defense mechanisms. Two big ones that we need to think about with COPD development are our HIV patients and our tuberculosis patients. And patients with either one of these can still develop COPD. Now, HIV, you may think, oh, why is HIV on here? That's a viral blood disorder. Well, yes, but it's also going to attack the immune system, where it's actually going to stop or prevent the normal inflammatory process from happening. And so it can have an accelerated development of COPD, especially if they smoke or if they've been exposed to anything. And then we know tuberculosis. If you've not learned about it, go back and research and review that content. Again, tuberculosis, we know that's a spore-forming infection in the lungs, and that can obviously cause some air trapping or airflow issues. Hereditary, we talked about the AAT deficiency. Remember, that's something normal we should have. And people who are lacking it then can have even more complications. Not just COPD, but they can also develop emphysema because of this. And it's a simple blood test. Accounts for about 3% of COPD, probably even more if we would really get in there and do some thorough assessment on our patients. Recurrent asthma. Now, COPD and asthma, we used to think that asthma was part of that compounded COPD diagnosis, but we're actually seeing in research that patients who have asthma and COPD are separate from each other. Maybe they had pre-exposed or pre-conditioned asthma, and then they develop COPD, maybe because of the asthma or maybe because of other reasons. But when we do see COPD with that chronic bronchitis and asthma, we call that asthma COPD overlap syndrome. Older adults may have both of those diseases, and it may be something where asthma has gone undiagnosed. Let's talk about pathophysiology, so the actual breakdown down to the cellular level of what's happening in COPD. These are your defining features. Again, not fully reversible, so something that can't come back to normal. It's airflow limitations during forced exhalation, so breathing out. And typically this is because of loss of elastic recoil, so just the hardening or inflammatory process of the bronchioles, as well as mucus hypersecretion, edema, and bronchospasm. So, we might see a lot of these areas of inflammation, but it could also be age-related because of the loss of recoil, which is a normal aging process. But then when we look at the pathogenesis, how complex it is and how many mechanisms it actually involves, we may actually start seeing, oh, this patient did smoke, this patient was exposed to this patient had, chronic inflammation or infections. And so, they kind of fit in a better mold now that we've done some more assessments. Another tip for you is when you think about the process of inflammation, whether you've learned that in integumentary, if you've learned that in inflammatory cardiac, or if you've learned that in your inflammatory GI tract, whatever the case is, understand the process of inflammation and what's really going to be happening, because if you can understand it, then you can understand what we're doing to treat it. So this is just a breakdown, again, understanding and not memorizing it, because memorization is not going to help you. But if you understand what is actually happening, then when we talk about the medications and the typical go-to treatments or even secondary treatments, then it's going to make a lot more sense for you. So when a patient has any kind of inhalation of whatever it is, noxious particles, gases, or if they have chronic inflammation because of chronic respiratory infections, either way, what we're going to see is mediators that are going to be released that can cause damage to the lung tissue. And that may be short-lived or long-lived. And so with COPD, what we're seeing first off during the inflammatory process is neutrophils, macrophages, and lymphocytes. And with that, we think infection. We think, the purulent, nasty infection. It's a little different with asthma. Asthma is more of an histamine release. So we see more of, first off, eosinophils, macrophages, or we might see mast cells. Those are all allergy-related types of cells. They still cause inflammation. They still cause pro-inflammatory cytokines, but the actual release is going to be a little different. So that makes a difference in also the treatment as well as some of the symptoms that we're going to see. So we still see inflammation, but we also can see the distance or the length of time of complications. And then we can also see the response to their therapy. So I'm going to give you an example, just kind of jumping the gun a little bit. When we have a patient with COPD, we know they're going to have neutrophils, macrophages, lymphocytes, right? They're going to then attract what's called leukotrienes. Leukotrienes are a type of enzyme that causes the sequence of events of pro-inflammation or inflammation. Now, with that, that means that we have leakage of fluid into wherever the inflammation is, that's going to cause increased mucus production. It's also going to cause vasodilation, which can then cause wherever it is to swell up and get red. So if we're talking about the respiratory tract, then we're going to be thinking about those bronchioles. And then it causes pro-inflammatory cytokines like tumor necrosis factors and interleukin-1, which then can still exacerbate and prolong the inflammatory process. So what do we do for these patients? What do we do? What kind of treatments are we going to give COPDers? Well, we can give leukotriene modifiers. Leukotriene modifiers are really helpful in decreasing that response, which is then going to slow the inflammation down. That makes sense to you, right? So then we can also see interleukin modifiers that can be administered to our patients. And that's going to also help decrease the inflammation to our patients. An example of, for example, our leukotriene inhibitor, like Zyflo, or Montuculast, which is singular, and I take that every day, and that helps with my allergies, my inflammatory process, and it's a long term. So it's really helpful for our patients in a maintenance effect. And then we also can even go further with, if our patients have asthma and COPD, we can even give interleukin-5 inhibitors or anti-interleukins. And that's going to, again, stop that inflammation. And that can be typically, it's kind of a last go-to because it's pretty invasive, but we can give injections to our patients, and it's kind of an add-on to some of their maintenance medications to fix that, especially if we're seeing exacerbation after exacerbation. So hopefully that kind of tied that together and make you understand how important it is to understand the inflammatory process and then what we're going to give our patients to treat that. So this picture is kind of a tie all together of the mechanism, the pathophys of what we're seeing. So on the left-hand side is your normal healthy lung tissue, bronchioles, alveoli. So you can see how nice and pink and open they are, how puffy your alveoli are. You can also see your bronchiole in this lower picture here. So one big thing that you can notice the difference is the airway lumen. It's open. Yes, there's some mucus in there because we constantly are going to have mucus, but it's open. That means air can flow through, inhale and exhale. We also see the smooth muscle of the bronchioles is nice and open, so it's relaxed. And then we have alveolar attachments, and these are kind of like a little elastin fibers, and they're nice and tight, and they're pulling tight on your alveoli. Look over on the right-hand side. The top picture up here, we've got some destruction of our alveoli. Look how gray and mottled they look. And this is all a process. So it doesn't start with the alveoli. It starts with the inflammatory process. I'm going to just zoom in just very quickly to this picture so we can kind of just break it down a little bit. So the inflammatory process is going to cause increased capillary refill, pull some more fluid in here, which increases mucus production as well as how thick the mucus is. And then, of course, all of those inflammatory cells, neutrophils, lymphocytes, macrophages, all kind of go to that site and kind of clog it up with all of the yucky stuff. And this mucus then can't really get cleared out appropriately, especially the farther down we go into the respiratory tract. So these are called bronchioles. They're really tiny, and they go to the site of our alveoli. And notice how the alveoli are kind of gray. They're not round and puffy, and it's because they're starting to collapse on themselves and they're starting to lose their ability to function. When that happens, we can't process gas exchange appropriately because that's where our alveoli, what they do. That's at the bed of the capillaries around the alveoli is where we do that gas exchange. So then the other part that we're seeing, kind of the beginning piece, is this hypersecretion of exudate, okay, which is normal inflammatory process. And it's because of all of those cells and our pro-inflammatory cytokines that's causing an overproduction. Not to mention, it causes vasodilation here, but it causes bronchoconstriction. So it wants to bring more blood flow to the area, so it makes the vascular space nice and big, but what it does is decreases the actual opening, so we can't get good airflow out. Another piece to look, see how the alveolar attachments are kind of weak and loose, and some of them are even broken. That's what can cause some of the alveolar destruction. So the pathophys of the inflammatory process, remember, it's not overnight, it's not one thing, it's not one cigarette, it's over a long period of time. This is the same pathophys picture that you have in, oh, excuse me. This is this, oh goodness. This is the same pathophysiology map that we just talked about. It's just in a different sequence of events of what you see in your textbook. But again, it's the same thing. So we've got some kind of noxious gas exposure, causes inflammation, causes remodeling of our peripheral airway, destruction of the parenchyma or the lung tissue itself, pulmonary vascular changes where we've got some nice thick vessels, we've got some destruction of our capillary bed, and all of these things combined then lead to what we consider COPD pathology. And look how many little subcategory problems we're seeing in our COPD, and we're going to touch on all of these whenever we get into the actual signs and symptoms. So again, this is just a step-by-step pathophys of our COPD. It just breaks it down a little bit more. Remember that our structures of our lungs can be destroyed, but it's not, again, over a one little sequence. It's going to be over some time. When we look at the supporting structures of the lungs, what I'm talking about is your actual chest, your bronchioles, and the ligaments. So when we start seeing over time this damage, we start seeing what we think of airflow obstruction. So air should be going in easily, but then what's happening in COPD is it's getting trapped. So it's remaining in the lungs. And so now we have a little bit less of a forceful expiration. So we can't get the air out appropriately. So that residual air then becomes really increased as alveolar attachments to our small airways are destroyed. And then the patient tries to breathe when the lungs are in an overinflated state. And then that's where they become very short of breath and their exercise capacity is limited. And this can lead to then a barrel-shaped chest, which is kind of that classic picture that we think of when we look at COPD patients. This is just a picture of the pathophys, what we're looking at as far as those dilated alveoli and how they can damage and how then air can get trapped into those sacs and can lead to overinflation. So now we've got trapped air. Now, what can happen then are things that you might have seen in clinicals or if you've seen in industry are called bullae or blebs. And bullae and blebs are on the outside of the lung. Now, it's not always in relation to COPD, but they can be. It can also be related to any kind of noxious gas or pollutant or any kind of inflammation process. This is something that's common in patients with hereditary AAT, as well as those who vape. Vaping has been really researched and led to blebs and bullae. And bullae are large air spaces in the parenchyma. Blebs are air spaces adjacent to the pleura. And so you can kind of see those on the outside of the parenchyma over here. So they look like little air sacs or blebs. And what we're concerned about with the blebs or the bullae is when they get too big or when they start to cause pressure and then the lung can collapse. And when the lung collapses, then we know we've got some major respiratory gas exchange issues, and that's where people typically end up with like a chest tube. So bullae, blebs can occur even from COPD as a complication. Other types of common characteristics of COPD pathophysiology is that mucus hypersecretion. So lots and lots of mucus production, especially with that thick white mucus. What we're concerned about is when that mucus then can become more yellow, more thicker, more, my husband uses the term buttery, like when you've got a upper respiratory infection. I know you're probably like, bleh, whatever, but it kind of helps you understand when that happens. Now we've got possibly an acute exacerbation of our bronchitis, and we've got an infection going on. And that's what typically is going to bring patients in to the hospital for a COPD exacerbation. Oh, and let me go back. When we have mucus hypersecretion, typically when we think of mucus secretion, if they can cough it up, that's great. But in COPD, especially if they have damage because of long-term inflammatory process and smoking, then their cilia, the little fibers that are supposed to help, or the finger-like fibers that are supposed to help pull the mucus up out of the respiratory tract, is not working. And then they can't get the mucus out. They can feel it in their chest. It rattles around. Typically, we can hear it. It might even be rhonchi, but it can't be cleared with coughing. So then it can lead into crackles. So then we have mucus that's stagnant there. Stagnant mucus that flows down into those smaller bronchioles. Again, keep causing the damage, keep causing the airflow to be trapped. And that's where we have that hyperinflation of the lungs, and that gas exchange is then going to be damaged. As we start looking at COPD, we're going to talk more in depth about pulmonary hypertension. You'll also hit it a little more later on when you get into more critical care type of setting or advanced med surge. But because of the loss of the alveolar walls, the capillaries that surround them are also damaged. Capillaries, remember, is part of the arterial circulation. When that's damaged, it's going to create an increase in pressure. It then puts an increased pressure in our pulmonary circulation. Now, we don't want our pulmonary circulation to be increased because we need a specialized amount of pressure in the pulmonary system. Otherwise, we're going to have some respiratory and cardiac problems. So we're going to have that resistance problem. And that can cause our right-sided heart failure, or what we'll look at in a little bit as cor pulmonale. So this, along with the thickening of the blood vessels, then can lead into pulmonary hypertension, which is going to have a much higher pressure. The only way to be able to measure that pressure, a couple of diagnostics tools that can assess that. Echo, especially if we do a transesophageal echocardiogram, or we can go in and put a capillary transducer into that pulmonary artery and really measure how much pressure is in there. It's an invasive procedure, but it's necessary if we start seeing signs and symptoms, which we'll talk about. And just to keep in mind, there's only two little concepts on here, but just to make sure that we're not isolating COPD, and if you've been in clinic or if you're a nurse already, you probably already know this concept, but COPD is a systemic disease as a result of chronic inflammation. And when we think about systemic diseases, we also need to think about osteoporosis, diabetes, maybe even cachexia, where that skeletal muscle wasting is seen. And I'm going to show you a picture of what a patient would look like when we think about our pink puffers or our COPDers. We also know that it's often coexisting with other cardiovascular disease. Most commonly, we're going to find out hypertension, all of those types of things. Clinical manifestations, again, typically are going to develop slowly. And when we look at that prognosis of our patient, we have to have how much airflow limitation we're actually seeing. So diagnosis is considered with chronic cough and sputum production, dyspnea, especially on exertion, and then exposure of those risk factors. So when you're developing your assessment, to make sure that you're really looking in on that thorough assessment of dyspnea. Now, dyspnea usually prompts what medical attention our patients are going to seek out. And usually it occurs with exertion in early stages, but then as the disease advances, we can have dyspnea at rest. Other things that we might see is chest breathing. So adults should not be chest breathing. Babies sometimes can chest breathe or belly breathe. That may be a little more common for them when they're using some of those accessory muscles, when they're, feeding or when they're crying. But in adults, we should not be using those intercostal muscles or those accessory muscles. This is inefficient breathing pattern. You might even see some wheezing or chest tightness as we start to progress, and this is going to feel very similar to like a muscular contraction. Characteristics of other problems that we might see systemically is underweight with anorexia, and that's where that cachexia syndrome is starting to look at. We have thinner arms, thinner legs. You might see that big chest and that big belly, but that's typically because of that barrel chest and that remodeling of the actual ligaments. Chronic fatigue, super tired all the time, and that's because of first of all, the exertion they're having just to breathe, but also because of the gas exchange issues. We don't have any oxygen carrying capacity, so then we might end up with, some poor perfusion to the rest of our vital organs. Paroxysmal coughing may also be so severe sometimes that it can actually cause our patients to faint, go into a fatal or go into an arrhythmia. It doesn't always have to be a fatal arrhythmia, or it can even fracture their ribs. So paroxysmal, remember, sudden onset coughing. And usually it's unexplained. They may just get strangled on some water, or they may just start coughing and they can't stop coughing. Some other physical examination findings you might see is a prolonged expiratory phase, so a prolonged breathing out phase. And the patient may need to breathe louder and normal for auscultated breath sounds to be heard. So when you're assessing them, you may have to have them open their mouth to really breathe so that you can auscultate that. You may hear wheezes, or you might hear depressed or decreased breath sounds. And that's really common, especially when we start looking at the more advanced stages of COPD. We also can see that remodeling where we see that barrel chest, and that's where the anterior and posterior diameter actually start to be equal. Typically, you're supposed to be twice as wide as you are deep, but then these patients may actually have the same kind of diameter. They will breathe in a tripod position, and tripod is not always sitting down with our elbows on our knees. We might actually see patients like leaning forward on things that's adapted for them. They may lean across. I think of, like when we go to football games or rodeos or something like that, and I see these men who are getting winded, and I say men because a lot of times that's what we see in the industry. They're leaning over the gates and they're having to take a breath and take a rest. And so that picture just kind of reminds me of what we see out in public. And then, of course, the classic pursed-lipped breathing. Pursed-lipped breathing is just that. It means that they're using accessory muscles like the neck to help with inspiration. So they're really breathing out pursed lip. This is a good exercise for patients who are hyperventilating, but patients who have COPD, this is a common thing that they're going to do. And it's just an adaptable thing that they've learned to do to help get them the respiratory breathing in that they need to. All other types of clinical manifestations we might see are polycythemia, cyanosis, And polycythemia just means that our hemoglobin concentration is very high. So it may even reach 20 grams per deciliter or more. And if they have a really high count, they are very high risk for developing clots. Their blood may be more viscous than normal. Now, really high amounts of hemoglobin is not always common. Sometimes the patients may have a lower hemoglobin and hematocrit because of chronic anemia. So it's not always polycythemia. They may actually have anemia as well. Excuse me. Last thing is we might see our patients, excuse me, let me go back to this picture right here. We may see some hypoxemia or hypoxia or hypercapnia. So there's 3 different terms that are totally different. So hypoxia is a decreased oxygen saturation, okay? Hypoxemia is a decrease in our partial arterial oxygen saturation, and hypercapnia is an increase in their CO2, specifically their partial arterial CO2. And that should make sense if you've learned anything about ABG interpretation or those normal values. And so when a patient is admitted into the hospital, you may hear these terms, COPD exacerbation, or probably this is going to ring a bell for you, acute on chronic respiratory failure with hypoxemia, with hypercapnia. And so that's a really common term because that's an ICD-10 code that people are going to be admitted for. And we have to know, do they have hypercapnia, which is that increase in CO2, or do they have normal CO2, but they have a decrease in their oxygen saturation? So really common. These patients over time are then going to develop a bluish red color of the skin. So we call them our little pink puffers. And so they're going to have that more typical cyanotic look around their mouth, or may even be a little grayer. Fingertips, hands are a little more gray, but then when you look more centrally, they may have like a reddish or rutted color to their overall skin. And that's because, again, of the increased blood flow that they're needing to compensate for the problem. They, again, have that barrel chest, but notice how this patient has kind of a thin stature. You can see the bony prominences in the clavicle, in the neck, in the cheeks, in the arms, in the ribs, but they have a very big chest, and he's kind of bent over, and that's where that osteoporosis or kyphosis is starting to represent some of the remodeling phase. So hopefully this helped going over the causes, the patho, and some of those classic types of symptoms. And what we'll do then is, again, go over in depth a little bit more on the diagnostic testing, the drugs, and things like that. So look for a separate lecture. If you have any questions, holler out.